Good morning. Hi, I'm John Moriarty. It's very nice to be with you. I apologize for being not there in person, but hopefully next year. I'm an interventional radiologist who has a special focus and interest on venous thromboembolism as it relates primarily to acute and chronic DVT, IVC filters, cable-related problems, and then pulmonary embolism. And so it's a pleasure and an honor to be here with you today. And as part of the Thrombosis Ireland team, I really want to say my hugest admiration for the work that you guys have done in helping patients, disseminating information that is vital to not just getting people through the acute problems that can cause the immediate issues, but really giving them the tools and the aid to get them back on their feet after a venous issue. And this is, as you know, an incredibly common problem, and it's fortunately an area that we have seen a lot of innovation, expansion in our ability to identify people who are at need of medical aid, and then hopefully give them more improved outcomes through interventions, medications, or indeed conservative measures. And so what I hope over the next short while that we have together is to share some of the newer things that are perhaps not as familiar to you as, for example, anticoagulation now is. So over the course of the next few minutes, I will run through a bit about two main focuses. One is if you get an acute DVT, so an acute clot in your leg or in your arm, but mostly in the leg, what are the reasons to have a clot removal procedure with someone like myself? And then the second is, suppose you develop post-thrombotic syndrome, and I'll talk about what that is and how it can affect people. What are the interventional options that exist now that maybe weren't always there? And how do we go about accessing them? So with that, let me share my screen, and hopefully we'll be able to learn a bit together. So, as I said, we're going to be discussing the interventional treatment for post-thrombotic syndrome, a condition that is incredibly common, that I'm sure is well known to all the people involved with Thrombosis Ireland. What it is it's a spectrum. So some people have the more milder end of the spectrum, some people have the more severe end of the spectrum, but post-thrombotic syndrome, I'll call it that, but it is also called, for example, post-phlebitic syndrome or heavy leg syndrome or post-clot syndrome. There are lots of different names, but I think post-thrombotic syndrome or PTS is the most common, and also the descriptor that tells you most about the cause of the problem, thrombotic issues, whether it's acute or chronic clot in the vast majority. And people who develop a blood clot, wherever they may have that, can go on to have a range of problems. In the legs, it's most commonly associated with leg swelling. Here you can see an enlarged leg that is dilated, that is shiny with less hair than the other side, because these are chronic skin changes that can happen. Frequently, these legs are hot. They have problems sweating, and so they're either very clammy or they don't lose the heat through sweat that the other leg may indeed have. They can also lead to other skin changes, usually deep within the calf area. And there's an area just around your inside of your shin bone called the gaiter area that we most commonly see venous issues and post-thrombotic skin changes happening first. And so when you're being examined by by a venous expert, this is the area they will almost certainly ask you to expose first. And here you can see some of those changes: pigmentation within the skin, a pockmark appearance to the skin, and this can go on to form other changes with fancy names like lipodermatosclerosis that you'll be able to see online. It is a spectrum. Some people get it more severe than others. Here you can see this more advanced change with the skin becoming very thickened, with changes of the skin pores, of the hair insertion sites. And here you can see what is close to, but not quite, a skin ulcer, a breakdown in the skin, which can then become super infected. And here you can see this area of ulceration here, again, on the inside of the calf in that classic gaiter area. This is a person who used to have quite a large ulcer that has healed. And over time, these things can be helped. It is not always a one-way trip. And so we want to make sure that if we can prevent it, we will. But number two, if they occur, we recognize it for what it is and hopefully get the most appropriate management. There is a classification scheme for this that, again, you might hear of. It's called the CEAP classification, with the CEAMP all standing for various things, but it's a 1 to 6 classification. And so you may see in your chart, or your doctors may be talking to you, wound care specialists may be talking to you about being CEAP 4, which is where you've got swelling and pigment changes here, all the way up to ulceration and open ulceration, which, for example, would be CEAP 6. And so the reason that, again, it is important to know these are that some of the treatments that we give, all the way from compression to grades of compression, will depend on where on this kind of range you fall. And unfortunately, post-thrombotic syndrome is incredibly common. Somewhere in the range of 20 to 50% of all patients with DVT, and this is a condition that is far more common than, for example, most solid organ cancers, things like breast cancer that we worry about all the time, that this is an incredibly common condition. And we know that, as I said, somewhere between 1/4 and 1/2 of all people, but it's probably up at the topper end of that. About 45% in a recent large study, the ATTRACT study, had post-thrombotic syndrome after developing their first DVT. And most people, when they get a blood clot, if they get post-thrombotic syndrome, they're going to get it in the first year. That if you are a year out from having your blood clot and you don't have symptoms, it's unlikely that you're going to develop it years later. However, it can be that over the time, if you have those symptoms by the first year, they can get worse. Now, of all the people who have post-thrombotic syndrome, somewhere in the range of 5 to 10% of those may go on to develop an ulcer. And so if you take all comers who have a DVT, the probability of developing a venous ulcer, now and again, there's big ones and small ones, we're talking all comers, over 10 years is in the range of 5%. So this is, again, a very high number, and a number that a lot of doctors don't recognize. So where part of the issue that venous specialists like yourselves in Thrombosis Ireland have is educating the medical community to say that just because someone has a blood clot and they get put on blood thinners is not the end of the story. These people are still at risk of developing a condition that can go on for quite a while, sometimes lifelong, and can cause severe problems with their quality and quantity of life. This is an issue that we encounter in many areas within venous health, where it just is not getting the recognition and the education that it is in other areas, for example, with people's arteries. Now, I said that we would talk a bit about what do we do about preventing it happening. For example, if you get a blood clot, is there some intervention that we can do to help? Well, the good news is I think there are. And I'm going to quickly just show a couple of trials. I'm not going to go deep into the trials, but just to show you that there is evidence that the things that I'm talking about can help. So in 2012, and you'll see that a lot of these are only in the last decade, that this isn't something that we've been doing for 50, 60 years, like we have been with, say, heart angiograms. This is newer, and therefore it isn't something that a lot of people have experience with, but it's getting better. So in 2012, a large study run out of Norway, so a population not too dissimilar to our own in Ireland, showed that if you have a blood clot that's above the mid-thigh, so not all blood clots, not just the ones that are at the knee, but the ones that are above that, because they're in the bigger veins, they're more severe, that if you give them lysis, a procedure called catheter-directed lysis, and that's CDT, or catheter-directed thrombolysis. That's where we put a little catheter in and we put a clot-busting agent in to get rid of the clot. This is associated with a significant decrease in the rate of post-thrombotic syndrome. 14% less people got it. So that is a significant improvement. And I can tell you, as someone who does a bit of cancer work, that we frequently will treat people who with medication where we don't expect to see as big a change as that. So 14% decrease is actually quite a big change, even though it may not sound like it. And importantly, in this trial in Norway, there were no serious complications from the procedure. It was very safe. Now, we know that from later follow-up that in fact, that 14% are the people who get it better immediately. But in fact, if you follow them out for longer, 5 years at least, that number gets better. And so that goes up to 28%. So based on this trial, what I say is that about a third of people will get significant benefit in their post-thrombotic syndrome if they have this lysis procedure done when they have an acute blood clot. Now, there's another big trial, which again, some of your doctors, some of your healthcare professionals may be talking about, called the ATTRACT trial. This is a big US trial. So a slightly different population to what we have in Ireland. And in almost 700 patients, they looked at, did post-thrombotic syndrome develop, but also, was it cost effective? How did it affect their quality of life? Did patients get better early with their pain and swelling? And what it showed is that, I've broken this out, this group here, and this is kind of a slide that it's difficult to go through. Not every patient should get this, but that this group here, this moderate or severe post-thrombotic syndrome with iliofemoral DVT. Now, I'm going to spend a moment just on each of those words. Post-thrombotic syndrome, we've explained. Moderate or severe means that you don't just have a small amount of leg swelling, but rather that you are on the greater end of the spectrum where there is leg swelling, but also significant edema, thickening of the skin, pigmentation of the skin, difficulty walking, any of those kind of things, all the way up to an ulcer. And that in people who have a blood clot above the knee, so not at the knee, but above the knee, then they are people who benefited from this procedure. And indeed, again, the people who were worse when they started got the most benefit. So where does that kind of leave us? This is the most modern, up-to-date information. As you can see, it was published just this year. And what it tells us is that if it was me and I presented with a blood clot above my knee that had caused severe symptoms, I would want to have this procedure to remove the blood clot because it gives me the best chance of not having post-thrombotic syndrome. It's not going to prevent everybody from developing it, but it is going to decrease the chance of me having it substantially. And therefore, that's what I believe. If, however, I present with a blood clot that's not that bad, for example, it's in the calf, but not the thigh, or my swelling is mild, but not severe, then I would say that blood thinners alone with compression and exercise are better than having a procedure. So the short answer when people say, oh, should I get a procedure to remove my blood clot, is you should get evaluated. You want to go to someone who knows this evidence, someone who can talk to you as an individual patient, go through you and your personalized risk, and hopefully give you all the options. But you should definitely get evaluated. Now, this is kind of showing some of what I was describing in slide form, and I will forward these slides to Thrombosis Ireland so that they're available for anybody who wishes to look back on them later. Now, what happens if you have already developed post-thrombotic syndrome? So we're now moving away from, okay, I have a blood clot, what do I do right now, to, I had a blood clot 6 months ago, a year ago, 10 years ago, and my leg has never been the same. I have leg swelling, I have pain, I have discomfort when I walk. It is frequently people describe a irritation at night, which can be anything from pins and needles to a hot, sweaty leg that they have to leave outside the covers, to people who feel a restless leg syndrome, that their leg is twitching all night. These symptoms are typically worse after a day of standing, walking, or exercising, and they are worse when the leg is hanging flat. So if people are sitting at a desk for a long time, they'll find that their leg is disproportionately bigger than its brother on the other side. Now, if this is you, or excuse me, what are the things that can be done? Because we want to prevent that from getting any worse. And we want to make sure that the person who has leg swelling gets improvement, but also doesn't go in the way of an ulcer. And that's where we come in. As I said, there are multiple symptoms. And so it is frequently the case that patients with post-thrombotic syndrome get sent all around the place. They get seen by either multiple GPs or multiple vascular people or multiple physicians who are involved in their care, hematology, interventional radiology, vascular surgery, and they will often not get someone who's united with them in their care and their goals of care. So it's important to find someone you trust who does a lot of venous work. And when that person sees you, they will evaluate each of these symptoms and then look for what we call the clinical signs. These are things like I've described: edema, skin changes, large veins like varicose veins, or ulcerations. And then we get to, why do people get post-thrombotic syndrome? And again, this slide is a little bit complex, so I'm going to spend a moment on it. We think that when people get a blood clot, two main conditions occur which can cause post-thrombotic syndrome. The first is what's called outflow obstruction. In other words, the blood can get into the leg in the artery, but can't get back out because the main route out through the vein is blocked. That leads to other issues, but increased blood pressure within the leg is one of them, venous hypertension. The second thing that can happen is whenever you have a blood clot in an area is you get an inflammatory response. In other words, the wall of the vessel gets all kind of beaten up, the whole thing becomes a bit scarred. And that then can lead to what's called reflux. That is where normally the blood only flows in one direction. For example, it goes in through the arteries to your toes and then comes back from your toes to your heart in one smooth channel. But now, instead of flowing all the way north, it will flow south as well, because the valves that keep it in position are damaged by the blood clot. That is called reflux. And the two of those things going together are what we're going to try and prevent from happening or improve if they've already happened. And this is the discussion that I would have with any patient with post-thrombotic syndrome. There are three main things. The first is A, B, C, D, E. A is activity. We want patients to be as active as possible for lots of reasons. Firstly, this is a lifelong condition and you need to get on with your life. And it's very important that people who have post-thrombotic syndrome are encouraged to keep their weight down, are encouraged to mobilize, to maintain active. The veins of the legs run in between the muscles. The deep veins run in between the big thigh muscles and big calf muscles. And as activity levels, especially weight-bearing activity levels, are kept up, then those veins are squeezed and the blood is forced out. The second thing, B, blood thinners. Blood thinners, as you'll have heard earlier in the discussions with Professor Nyonla, are critical when it comes to making sure that the clots that are already there do not get bigger, and as well prevent any new clots from occurring. So that's A and B. C is compression. These are compression stockings, and this is a mainstay of treatment. Compression stockings are very effective. They're pretty cheap. They are not the most fun to wear, especially in the majority of cases, people are not getting them properly fitted. And so what you want to do is get a fitted one for you. There are pharmacies that are very good at this within Dublin, Cork, Galway, major towns. They will have a pharmacy that will measure you for this and order in the stockings for you. And getting one that fits you and then getting it again when it loses its elasticity is very important. And what the stocking does is it fights the force of gravity. It compresses in the leg so that the blood that is trying to kind of, be pushed outwards by gravity sitting on top of it is forced inwards and upwards. And so that helps prevent edema and swelling. Most people require compression stockings after a blood clot for the daytime. Wearing it at night when you're lying flat, particularly when your heart and your legs are roughly the same level, is not required. So putting it on first thing in the morning and then wearing it as much as possible during the day. These are the instructions that we tend to give almost all patients with post-thrombotic syndrome. D are drugs and devices. There are some drugs and devices that are going to be of benefit, and I'm going to talk to you a bit about that in a while. These are things that are relatively newer and that I think a lot of people don't have as much experience of. Those drugs and devices are targeted towards the next two issues that you see on the screen: venous reflux and venous obstruction. And I'll talk to you about how we deal with each of those. Quickly to say that the E is exercises. And one of the things that people ask is, how much exercise should they be doing? And essentially what it is you want to be doing enough leg strength and weight-bearing exercise so that you are building muscle within the leg, and that this has been shown to be of good benefit. What about drugs and pharmacotherapy? There's been a lot of interest over the last few years in different medications for post-thrombotic syndrome. And to cut to the chase, none of them have been shown to be of particular benefit. You should be talking to your doctors about blood thinners, but other medications, and some of which you will see peddled online quite a bit, things like gluticides, hydrosamine, and diflurodate, these really have not been shown to have any benefit. And I personally don't believe that my patients should be on them. So then we get to the interventional treatments. And the first of these relates to venous reflux. What are we talking about here? As I said, normally the blood flow comes out of the legs and it goes in one direction, north, up out of the legs. And it's prevented from flowing back down by these things called valves. So these are normally within our legs. We have several hundred of them in our calf veins, and then a few throughout the thigh veins and very few in the pelvis. But these prevent the blood flow going backwards. If they are damaged through whatever mechanism of inflammation and blood clot, then what happens is the blood flow can go down and these veins get bigger and bigger, and this causes increased pressure within them, varicose veins, and can cause an exacerbation of this post-thrombotic syndrome. And they can be all the way from kind of mild veins where you get kind of dilatation of the skin veins like you see here, all the way up to big ropes that extend all the way into the thigh. Some people get them across the belly, some people get them in the pelvis, some people get them in the vagina or vulva, and some people get them as hemorrhoids. But these kind of large varicose veins are incredibly common. And if you have post-thrombotic syndrome, they can make it considerably worse. And so the good news is there's treatment for it. And it used to be that you'd have to go for surgery. It was a big old procedure where these veins would be stripped out. That is rarely done now. And most of the time you'd go to an endovascular interventionist, someone like myself, but there are many others who will do what's called a laser treatment. And that's where putting a small needle into the vein in the clinic. So it's usually a day procedure, come in the morning, go home a few hours later, run the laser in the vein, and then essentially what the laser does, it heats the inside of that leaking backwards vein so that it closes it. And this then closes the vein, prevents it from leaking backwards, and hopefully improves the varicose veins and the hypertension. And so here you can see in this patient here, this is the pre, this is the post. Cosmetically, obviously, this can be a big change and can be of great benefit to people who want to have better looking legs. But if you have post-thrombotic syndrome, it can be of great benefit in preventing development of those skin changes that we talked about, particularly ulceration. And so here's an example of a case where this patient had a combination of compression, as you can see here, as well as reflux therapy where we used laser or injection. And this was the ulcer, huge, big area, very nasty, ready to get infected. This is after wrapping. This is after a month, it's beginning to heal, 2 months, 3 months. And I like this for not only giving people the visualization of improvement and to show what it can do, but also to say that this can take a while, that it is not an overnight process, unfortunately, and the healing when people have problems with their veins can take months, but hopefully it'll happen. Now, then we come to venous obstruction. That's what we're talking about when we're talking about blocked veins, and one of the biggest areas of progress over the last several years has been in the management of this venous obstruction. So how do we do it? Well, the first thing we do is we want to see if the veins are blocked. And most of the time that's with either a CAT scan or an ultrasound or an MRI. CAT scan is usually the fastest and easiest. And what we're looking at most of the time are the veins of the pelvis. We want to see the entire leg, but we want to see if the blood clots that come out of the pelvis here, coming up to the IVC, as you see here, have clot on them, whether they are open or closed. Because if they're closed, there are things we can do to help with it. And you can see here, sometimes we find things that we expect and sometimes things we don't expect. If you're not used to looking at it, these green arrows are pointing to the veins and they're full of clot. The little bright things beside them is wide open blood vessels. Here, these are veins with clot within them. And we want to image all the way down to the knees. Here you can see these are this person's kneecap here, and we can see the blood clot going all the way down. So this would be a large DVT, a large blood clot, someone who would want to get this out. Just again, to show you some examples, this is an MRI scan showing the same kind of thing. These are blood clots that are there. MRI is less available. There just are fewer of them in Ireland. The waiting times to get them in both the public and the private tend to be longer. And also, they are a little bit more difficult to interpret. So more places will have CAT scans and the ability to give a good CAT scan read when they're done. One of the things that we can see with either an MRI or CAT scan is a blockage to the veins of the pelvis. I'm going to talk about that. This is called May-Thurner syndrome. And what that is, you know, we're built symmetrically. Our right arm and our left arm are essentially identical. Right and left legs are identical, but we only have one heart. And so all the blood from the left leg has to cross in the pelvis to the right side of the body to get into the right side of the heart. And as it comes across the pelvis, it can be narrowed by what's in front of it, which is the blood vessel. And if you're used to looking at things here, you'll see that this is the blood vessel on the right. This little slip of the thing is the blood vessel on the left, and it's narrowed. And this blockage is extremely common, somewhere in the range of about 14% of all men, 19 to 25% of all women have this blockage. And it can be associated with blood clots, and it's one of the reasons why leg problems like post-thrombotic syndrome are much more common on the left than on the right-hand side. And you can see an example of this May-Thurner syndrome with post-thrombotic syndrome and here, where this is what the leg looked like on the day it presented. The patient came in with a big, heavy, hot, red, sore leg. This is after we got rid of the blood clot And this is the day after the stenting, and you can see the leg has returned to essentially normal. And stents are metal cages that are placed into the vein to relieve that obstruction, to open up the vein so that the flow is back to normal. And frequently in people who have this problem, they get stents. Another thing just to bear in mind is that if you're young and you get a blood clot, if you're under 50 and you develop a blood clot, it could be that there's what's called an anomaly. And so this is where we're not all built the exact same. Some people have one pipe that goes in the usual location. Some people have two. And if that's the case, then it can lead to downstream issues. And so it's frequently the reason why in young people we'll get a CAT scan or an MRI scan. Now, I'm going to wrap up in a few moments, but I wanted to quickly describe how we go about it so that if you or anybody you're talking to ever wishes to know if this procedure is for them. Most of the time, this is what's called a day procedure. You come in the morning, go home the same day. And we do it with you lying in your tummy because we use the vein behind the knee, the popliteal vein, to place a very small tube. These tubes are less than the width of a pencil. And here you can see this is one where we've put it into the vein behind the knee and also behind the ankle. And sometimes we do both. But the majority of the time, we use the vein behind the knee. And then we inject a dye. This is called a venogram. Here you can see on the pre-image here, before we did anything, that there was blockages to flow. This is then after we have dissolved the blockages, removed them, sucked them out. There's a lot of things we can do now to get rid of the blockage. And you can see here where previously there was no flow. Now we have this nice big flowing highway for the blood to go along. And as we come up into the pelvis here, you're going to see this is the pelvis here. This is a balloon. This is an angioplasty where we are stretching the veins of the pelvis. And in this sort of patient here, where you can see this big leg, where this patient has had issues for many years, a thickened skin, hot leg, immobility, difficulty moving. And here you can see after the treatment, several months later, back in my clinic, the leg, not perfect, but much, 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 much better than was there, and almost the exact same as its brother. Now, this can also happen within the arms. Here you can see a case where it involved the arms. And essentially what's sauce for the goose is sauce for the gander. The way we treat it is somewhat similar, where we get rid of the blood clot, and if there's a blockage, we try and open it. There are some differences with arm DVT to leg DVT, but that's kind of getting into the weeds a little bit. So to kind of wrap up, I want to thank the organizers again, particularly Anne-Marie, for the very kind invite. It really is an honor, and I apologize for not being there with you in person. But I look forward to any feedback you have, and particularly I look forward to being at future meetings. Acute DVT is super common, and some TVTs, particularly the DVTs that are big in the thigh and causing a lot of symptoms, they should get treated early. So they should be referred to an interventional specialist to prevent post-thrombotic syndrome. And post-thrombotic syndrome, it's a range. Some people will have mild, some people will have severe, and every patient is different. And therefore the treatments on offer are different depending on where on that range of the post-thrombotic syndrome spectrum you come. Most people get compression, elevation, and exercise. These are the mainstays. And then frequently, if there is venous reflux, varicose veins, high venous pressure, or obstruction, then an interventional radiologist, someone like myself, and there are many now around the country, fortunately, then we have a role in relieving those and giving symptomatic improvement and hopefully improving not just the symptoms now, but in the long term as well. But I will say that this is always done as part of a team-based approach, because this is a condition and a set of conditions that are best managed with experts like hematology, experts from other fields of medicine and outside of medicine. The psychological impact of having a blood clot is not minor, and support from societies such as Thrombosis Ireland are critical in making sure that everyone can get through this to the best of their ability. So with that, I want to thank you again for your invite, congratulate you on your meeting, and look forward to seeing you in Dublin next year. Thank you very much.